Okay. Thank you very much for joining us for our discussion
hello everybody. Hello everybody. Thank you, the organizers of South Sudan Women Intellectual Forum, for giving me such an opportunity. And also, I would like to thank the initiators of this platform that has given us an opportunity as South Sudanese intellectual women to share knowledge and expertise and to showcase our talents and skills. I think it's something that deserves appreciation and acknowledgement. I've been tasked today to talk about HIV as a director of HIV in the Ministry of Health. And before I embark into my talk, it's important to know that HIV is a public health problem. This is a global problem. And sub-Saharan Africa, in which we are part of, seems to be contributing to the majority of new infections worldwide. In South Sudan, the burden of HIV, our national prevalence is 2.5%, but there are some states which have higher prevalence, like Western Equatoria, followed by Eastern Equatoria, followed by Central Equatoria. But as of recent, some states like Jonglei and Lake State have also started showing high prevalence of the disease, unlike in the past. Myth about HIV that's important to note, and these myths affect access to service and affect people having treatment. The misconception in South Sudan is that HIV is a foreign disease. Most people think that it comes from Uganda and Kenya and neighboring countries. But unfortunately, it is not a foreign disease. It's just right here in South Sudan. It's real. One other misconception is that even within the country, people outside Equatoria thinks it's a disease of Equatoria, because of the highest burden being in places like Western Equatoria and Eastern Equatoria, which are border states to DRC and to Central African Republic and to Uganda. But as we speak now, there are cases of HIV infection right in the deep in cattle camps in Jonglei and in Lake State. So that shows that HIV is not a disease of Equatoria, but it's within the country and it's in all the states of South Sudan. Another myth regarding HIV is that people think that when you are diagnosed with HIV, it's like a life sentence. It's a death sentence. But no, not at all. Nowadays, people are living with the virus for 30 years, 50 years, and they're living healthy like anybody else. Another myth or misconception on HIV is that when you have HIV, you cannot have children. But many positive men and women are having kids, and those kids are negative, especially with the advent of PMTCT, which is prevention of mother-to-child transmission. We've had a lot of families which are HIV positive, living with the virus for many years, and their kids are very healthy like anybody else's kid. So that's important to note as well. Other misconception and myth around HIV is that when you're diagnosed and you get treatment, you take a lot of pills. But nowadays, there are pills, you can have a combination of more than 3 drugs in one pill, and you don't have to take a dozen pills like other people think. So these are some of the myths on HIV. I was attending one of the talk with youth, and one of the kids said that where people are defining AIDS, and he said AIDS stands for American Intervention to Discourage Sex. That by itself is a myth, because if you think that that this is the definition of AIDS, it means that people are not yet aware of HIV. Some people think that when you are HIV positive, you cannot get married. But I tell you what, we have a counselor who is very proactive. She's been working with us for a long time. She works in the military hospital, and she's been working like a matchmaker. She matches clients living with HIV, and they get married. And famous quote in the HIV field saying, "You equal to you." When you've been living with the virus, you're taking your medications regularly, and you are on treatment for a longer time, the level of the virus in your blood becomes undetected, and undetected equal untransmissible. You equal to you. So when you don't have the level of the virus in your body becomes really like not detectable, you can have your kids, you can practice sex normally, even without using a condom, but we still ask people to use condom. One of the other myths in this country is that people don't like to use condom.
Thank you. Dr. Victoria, can you hear me? Okay, I'd like to thank Dr. Victoria for giving us that background on HIV/AIDS. We know that HIV is surrounded with a lot of myths and a lot of misconception, and I think that was what she was
Sorry,
going
my line
into
keeps cutting
when
off.
we started the conversation. So just a little introduction. Today we'll be discussing HIV/AIDS, as Dr. Victoria has said, and we will go into a clinical discussion. We'll also talk about nutrition. We'll talk about mental health. We will talk about stigma, and we will focus on some aspects of policy which Dr. Victoria is going to talk about. We are currently facing a pandemic that is similar to the HIV pandemic in the sense that it is caused by a virus, coronavirus. And as Dr. Victoria has aptly stated, just like coronavirus currently is surrounded by a lot of myth, HIV/AIDS has been surrounded by a lot of myths since the 1980s when it was first discovered. And some of those myths are specific to certain environments, and some of them uh, are worldwide. So one of the ones that I came across was about the origin of the virus. And some people believe that it was bioengineered for population control, and the people who say that it originated in Central Africa from cross infection from monkeys because of their tradition of using wild meat and hunting game. So Africa has some of the highest number of cases of HIV in the world. By 2018, about 25.7 million people were living with HIV, and half of those cases are actually women. So women account for about half of all the cases of people living with HIV. And mostly it's young women who are affected, about 10 to 24 years. And what I came across was that every week about 6,000 young women are infected with the virus. So we know that HIV disproportionately affects women and adolescent girls. And this is mostly because of an equal cultural, social, and economic status. And this puts them in a vulnerable state and makes them more at risk. And access is therefore also an issue because of these particular reasons. Children, on the other hand, are vulnerable because they depend on adults for access to care. And if the adults are not able to take them to be tested or to get medications, then they end up not accessing care as they should. The other thing that we want to look into is stigma, because a lot of people living with HIV are exposed to stigma. They're stigmatized in the workplace, at home, in the community, even in healthcare. And that is something we have to look into because we're dealing with a population that is already marginalized, and this makes them even more vulnerable. So we hope this discussion today is going to be able to educate the audience and demystify some of those issues surrounding HIV. And we would like to request the audience that if you have any further questions, you can post them on our Facebook wall. If we're able to get to them, then we will answer. For those who are not, then the panelists have graciously agreed to answer when the discussion is over. So I will start by officially introducing Dr. Victoria, although she had already given a brief introduction of who she is. So she is the director for HIV, AIDS, and the STI department in the Ministry of Health. She's worked in Australia as a general practitioner for a few years before coming back to the country. She's also a member of the Australia Society for HIV Medicine and a member of the Technical Advisory Committee for the African Society of Children Living with HIV/AIDS. She presents health programs, and currently she is a presenter of a health promotion program called Your Health. She was also a finalist for the Irene Krestav Award, which is given to refugee women who have contributed to their communities and made an impact. She will be speaking mainly on government policy and support for persons living with HIV. Next, I would like to introduce Dr. Melvin Sindani. Is a graduate of Kampala International University and a medical doctor by training. She's currently doing her residency in pathology in the University of Nairobi and works at Kenyatta National Hospital, which is the premier referral hospital for Kenya. And she is also a director at St. Irenaeus Medical Services in Nairobi. She's very passionate about healthcare, and we'll be speaking about the medical perspectives of HIV. She has graciously accepted to take over some of the questions we were going to ask Dr. Ayat, who unfortunately cannot be with us because our platform is not accessible in Sudan. So we hope to be able to engage her in a later topic. Then I would like to introduce Nibol Rachel, who is a South Sudanese writer living in Kampala, Uganda. She's a student of, she was a student of clinical medicine at the Indian Institute of Health and Allied Sciences. She's passionate about mental and psychosocial and sexual reproductive health, especially among the youth, and she runs a blog, which we will indicate in our group so that you're able to access some of her writings. She tackles these topics in this blog, and she believes in the power of social media to create a positive impact among the youth, and also volunteers at local clinics and drugstores in her free time and researches on the mental health challenges among the youth. She will be speaking on mental health in HIV. So I'd like to welcome you all to the panel today. Welcome, everyone. Okay, great. So we'll just go straight into the discussion. Dr. Victoria, I'm sorry I cut you short a bit there. You can unmute yourself. Dr. Victoria? Okay, I think Dr. Victoria is not getting me. So we'll go to Dr. Melvin. Dr. Melvin, can you hear me? Could you please unmute yourself? Thank you, Dr. Melvin.
Yes, I can hear you.
Thank you. I would like to ask you the first question because we need to set the stage for this discussion. So could you help to define what HIV is and what AIDS is? I know very many people are confused about the difference between the two. And maybe after that, you can give us a bit on statistics in Africa versus the world. I think Dr. Victoria mentioned a few things about South Sudan, but if you can just mention when you're comparing women and children to men or to the general rates of HIV in the world, how do they compare? When you're comparing Africa to the world, how do we compare?
Okay, let me start with your first question, the definition and the differences. HIV in full, it's human immunodeficiency virus, and it's when the virus attacks the cell that helps fight infection. It attacks the immune cells. And AIDS, it's the late stage of HIV. It's when your CD4 count is below 200 and you're more prone to opportunistic infections such as cryptococcus. I think Victoria will give more definition if I've left some things out. The statistics globally, 37.9 million are living with HIV currently. Out of that, 1.7 million are newly infected, and 1.6 million are between the ages of 15 years and older. Among that, 160,000 are children. So HIV affects everyone. In Africa, HIV is more likely to affect children between 15 to 24 years old as compared to men. And 1 in 5 new infection is among the teenagers. Out of that, 25.7 million are living with HIV, 25.7 out of the 37.9 million are in Africa. So you can imagine how HIV affects Africa as compared to the rest of the world. And 1.5 million are in children. Then up to 10% of the 25 million are women. In South Sudan, there's limited data, but what I got is it's between 150 to 200,000 people. People should do more research on this. I think if you ask the organizations, WHO and UN, some of you who are more interested in research should venture into that and help us fill in the gaps. Out of the 150,000, women are.
I think there's a little problem with the internet. I can see Dr. Melvin seems to have hung a bit there. So we'll go back to Dr. Victoria. Dr. Victoria, can you hear me? Nibol, can we? Okay. Melvin, sorry, go ahead.
Children are fewer, and there are about 1,000 people living with HIV children,
Hello?
according to the research.
Dr. Victoria, can you hear me? Hello? Okay, I think we got you guys back. Dr. Melvin, can you hear me?
Yes, I can hear you.
Okay, please continue. Sorry, I think we had an issue with the internet there. Please continue.
It's okay. I was saying in South Sudan, the data is limited. So guys who are interested in researching about HIV should do this more. Hello? Okay. Approximately 3% of the population is affected. That's about 150,000 to 200,000. And most of them are adults between 15 to 49 years old. And that's about 2.5% of the population, of the total. And from that statistics, 55% are women. So women are more affected than the other gender and children. And there are very few children living with HIV in South Sudan currently. That's what I have for now.
Thank you. Thank you so much, Dr. Melvin. I think we'll go back to Dr. Victoria. Dr. Victoria, could you please unmute yourself as Dr. Melvin mutes herself? Dr. Victoria, can you hear me?
Unmute.
Dr. Victoria, you can hear me? Okay. So, Dr. Victoria, maybe you can tell us, unmute yourself. Unmute yourself, Dr. Victoria. Sorry, it seems we lost Dr. Victoria here. So Melvin, I think we are stuck with you for now. So,
it's okay.
Dr. Melvin,
yeah.
Maybe you can give us a brief overview of what the risk factors for acquiring HIV/AIDS are, and why women specifically are at risk. Or just give me a minute. Let me see if Dr. Victoria is able to continue answering.
Okay.
Dr. Victoria, you can hear me? Okay, Dr. Melvin, just mute yourself. Dr. Victoria? Can you hear us, Dr. Victoria?
Yes, I can hear you, Anne. Thank you, Dr. Melvin, for information. Actually, South Sudan has estimated number of people living with HIV around 190,000. 190,000 people estimated to be living with HIV. Among the 190,000 people, the majority are women. Majority are women, and
I'm sorry about that. As usual, the internet in Juba is letting us down. However, I think Dr. Victoria will be back in a minute. We'll continue with Dr. Melvin, and as we wait for Nibol to get back on the screen. Sorry, Dr. Victoria is back. Dr. Victoria?
Yes, Anne. Sorry, my network keeps cutting off. My network keeps cutting off. I said earlier that we have 190,000 people estimated to be living with HIV, and among the 190,000, majority are women. We have not done any population-based survey as such, like other countries, but most of our data is based on the spectrum estimate, which is organized by UNAIDS for countries to assess and to monitor the data on HIV. So with our data, we have a coverage of the ART or people on treatment around 30% of people of the 190,000 are on treatment. The pediatric coverage or children on treatment is very, very little, and we have like 9% children on the moment because we don't have the right infrastructure in place, and also children tend to come late for treatment. They come late, and also testing or the early infant diagnosis in the country. We used to send samples to Nairobi in the past few years, but now we have the capacity to do it in the country, and we're going to scale up, and hopefully we'll be able to diagnose children early enough so that we can put them on treatment. But one of our biggest challenge is the issue of pediatric HIV in this country. So this is basically the little data that we have on HIV. It's more on program data and spectrum estimates, but we have not done any population-based survey as such because of funding.
Thank you, Dr. Victoria. I understand what our limitations are, and hopefully, as you've said, we will be able to test children early and be able to get those estimates with time, and hopefully that will make a difference. So maybe a next question for you, Dr. Victoria, before the internet lets us down again. So are there specific policies that have been put in place by the government to reduce the spread of HIV in South Sudan? And does that policy have a specific focus on women and children living with HIV?
Yeah, actually, South Sudan has developed HIV policy in 2006, and it was reviewed in 2016. It's still pending in Parliament, but the core value of that HIV policy is to ensure that people living with HIV have access to treatment, and also ensure that vulnerable groups like women and retainees and IDPs are also having access to treatment. So there is policy in place. The policies are there. The National Strategic Plan also ensures that care and treatment is provided to everybody. And the HIV policy has a right-based approach and a human rights approach that makes it easy for key populations and other groups to access treatment to HIV. And that policy is in line with international declarations and also regional declarations like the Maputo Protocol and the Abuja Protocol, and also in line with national legislatures and laws of this country.
Okay. I wanted to know what are the specific indications in the policy that look into the vulnerable population, in the sense the women and the children. What is specifically different about our policy that covers
well, it's not a policy that it's a policy that all pregnant women are screened for HIV during antenatal to ensure that they are if they are enrolled in PMTCT, prevention of mother-to-child transmission, to ensure that they have healthy babies. And also we have developed a stigma index. It was a study that was developed, and it has guidelines to ensure that dealing with the stigma, because it's one of our biggest challenges and it's one of our biggest hindrances to access to treatment. Women have often undergone problems, things like intimate partner violence, and also GBV has been addressed in the policy. And of recent, the Army or the SSPDF has developed their strategic guidelines, and they've also developed the policy in SSPDF that also has human rights issues and gender-based issues, because most times you find that women, when they are diagnosed positive in antenatal and they are told to bring their partners for testing, they end up in problems, ending up at times they even end up with family breakdown because men don't want to come to get tested. And when the women are found positive, they are the ones who are, name called, and they are found to be the issue in the family, and it brings a lot of problems in the family. The policy is clear on addressing things like gender-based violence and making sure that rights of women are respected. It has a gender-based approach, but sometimes implementation could be a problem.
Okay. Thank you, Dr. Victoria. If you could mute yourself. I'd like to go to Nibol. Nibol, could you unmute yourself, please? Nibol, can you hear me? Okay, Nibol, please unmute yourself. Sorry, I can't seem to hear you. Nibol, yes, can you hear me now? Can you hear me now, Nibol? Okay, I'm not sure if everyone else can hear Nibol. Okay, well, okay, I'm not getting you, Nibol. So what will happen is that we'll go to Dr. Melvin. Could you please mute yourself, Nibol? Okay, just mute yourself for now. We can go to Dr. Melvin and then we'll get back to you.
Okay.
Dr. Melvin.
Yes.
Let's look more into the medical aspects of HIV. I think we want to know how does someone know or suspect that they may have HIV and therefore seek testing so that they can know what their status is. But what are the symptoms and what are the signs that one should look out for? What is it that doctors look out for, and what should the individual also look out for to know that I have this infection and I should a possibility of having a HIV infection and that I should seek care?
Okay. First of all, the symptoms vary from person to person. Not everyone will experience the same symptoms. Number two, the symptoms also changes from children to adults. Let me start with the general. You'll have persistent headache, a lymph node swelling, swelling under your. Let me just point them here, 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 and your inguinal region. You'll have a dry cough. You'll have muscle pain, joint pains, flu-like symptoms on your skin. You'll have rashes. There's diarrhea lasting for more than 1 week, nausea, vomiting. Yes. So those are the general symptoms you might be experiencing.
So we know that you're a pathology resident, and therefore you people deal with a lot of diagnoses and testing and checking tissue samples under the microscope. And I think you would be able to enlighten us on how is HIV diagnosed? How do doctors know that I am HIV positive or I'm not? What are the tests they do, and what are they looking for when they're testing for HIV?
Okay. For testings, there's a primary test and there's a secondary test. The primary test, there are two. There's a rapid kit, which we usually do in the hospital, a 5 minutes testing. And there's one which you can do at home. It's called an oral test kit. It takes less than 5 minutes. The secondary testing, those are confirmatory tests. There's one known as ELISA, there's one known as PCR test, and there's one known as Western blot. But you have to do the primary test first before you go to the secondary test. Secondary tests are done to confirm the primary tests.
Thank you for that, Dr. Melvin. I think we can try Nibol now. Nibol, are we able to, can you hear us? Unfortunately, Nibol, I can't hear you at all. I don't know, can anyone else hear what Nibol is saying? Dr. Melvin, can you mute yourself, please?
Yeah.
Dr. Victoria?
Yes, Anne, I can hear you.
Please.
Yep.
Nibol, you can hear me? Okay, fine. I think we have an issue with Nibol. So Dr. Melvin, could you unmute yourself for a minute? As Dr. Victoria mutes herself. Dr. Melvin.
Yes.
Dr. Victoria has mentioned a number of things about sexual and gender-based violence and about the policy that protects women against that, and the fact that women might experience violence when they're diagnosed with HIV/AIDS. And I wanted to find out, how do health workers ensure confidentiality, and when it comes to disclosure, especially to significant others, their partners, how do we navigate that, especially with the real risk of these HIV infected persons being exposed to violence because of having a positive status?
Okay. So first of all, when you come to the hospital to know your status, there's the 5 C's we usually do. One is counseling. Counseling is done normally, one, for support, for both your partner, for the community, and for the group. 2, if you have any questions regarding your status and how to disclose it to your partner. 3, for mentoring systems. Number 2, confidentiality, which runs both ways, both to your partner and to the health worker who's testing you. Health workers are trained not to disclose people's status to anyone. Number 2, if they disclose your status to anyone, there's a liability they'll have to face. So there's no way, no how they'll disclose it. Number 3, there are files which are kept in a confidential place, in a safety place where no one can be. Special people are, the access is limited to special people. Not everyone can be. I'm looking for a word to put it. Not everyone should not have an access to your file. How should I put it? Something like that. Yes.
So, okay, great. That's true. Health workers are trained not to expose anybody's status to anybody else unless that individual has agreed for that to be done. What I wanted to find out is when it comes to disclosure to their partners, what happens? How do you, because there's a real risk of the virus being transmitted to their partners or their partners also being infected. How do you navigate getting this person who has just newly been diagnosed to actually disclose to their partners that they are HIV infected and assist their partners in seeking care or seeking a test to determine their status?
There are usually counselors who are told to go to their homes personally. So when the counselor goes to your home, that counselor is trained on how to handle a tough situation, how to neutralize any situation that will happen in that home when discussing about their status. It's usually called home-based counseling and care, something like that. So the counselor comes to your home when your partner is tested positive, sits down with you and your partner, talks about everything, all your questions, and how to move forward from there, even linking you to the nearest facility for help.
Great, thank you. So if you can mute yourself, Dr. Melvin. So you basically talked about the medical professional themselves, especially the counselors, being able to sit down with both partners and discuss HIV testing and possibly encourage the other partner to test. I think the other things that usually happen is maybe even encouraging people when they go for their first testing to go with their partners, and also a mediated kind of disclosure, which is what you've mentioned, where there's a third party that the partners trust, who is able to guide them through the counseling and guide them through the testing and talk to them about treatments and what is to happen when they're found either HIV infected or not. And it's true that disclosure exposes women to a lot of violence. That is something that has been known, and being ridiculed and being told that you're actually the one who has brought this infection to the home. So Dr. Victoria, if you could please unmute yourself. I think I liked what you were telling us about the policy, that the fact that the HIV/AIDS policy includes issues about gender-based violence, and there's a push to cover that when it comes to HIV services. And what I wanted to ask you, Dr. Victoria, if you could unmute yourself, is how is the government able to implement the policies for HIV/AIDS and its prevention, given the cultural norms and the biases and stigma against people living with the virus? What are the challenges that you face when it comes to implementation of these policies, especially in our community?
Honestly, Anna, I could not hear most of your talk because your voice is breaking down. But gender-based violence issues are addressed clearly in the policy. And as a program, we have designed ways to support women that have We have a GBV one-stop center at Juba Teaching Hospital that women undergo counseling. People who have been raped are counseled and they are tested for HIV. They are given post-exposure prophylaxis, and they're given most of the services. And also, we have civil society organizations supporting HIV, mainly NEPO. NEPO stands for National Empowerment of Positive Women United. It's a civil society organization supporting women who live positive. And normally they do a lot of awareness raising for women to let them report cases of gender-based violence, intimate partner violence, so that they are referred to the center to be supported and given. They're even given legal service as well and legal support for them to address cases of rape and other domestic violence. So the policy is clear. Gender-based violence is not condoned, it's not entertained. And recently, the Ministry of Gender has done a lot of work. And
okay, sorry about that. Dr. Victoria might keep on dropping off because of the challenges we are experiencing with the internet in Juba. So, Dr. Melvin, I'll get back to you later. But Nibol, are you able to hear me clearly now?
Yeah.
Nibol? Nibol,
I think
yourself,
you can
please. Sorry. Nibol? Yes, Nibol, could you please give us a brief overview of some of the mental and psychological effects of HIV infection in those who are infected and those who are affected? By affected, I mean those who have siblings or parents who have HIV infection. Nibol.
HIV affects women. Okay, to those that are affected, it sort of causes depression, and AIDS causes depression in two ways. It can directly cause depression, like when HIV damages the brain and causes inflammation of the central nervous system, the brain, and the spinal cord, and this leads to things like forgetfulness and confusion. And then also HIV, it causes anxiety amongst the patients, like those who have been infected, and then even to those that have been, and actually these women they get suicidal thoughts, because I mean because people think to have HIV, somebody must be a whore, has been sleeping around, and so they already feel condemned culturally and then also religiously. And then some of these patients have what we call acute mania. Mania is, and it's so hard to diagnose in some of these women, because it looks something good, because if you have mania, you're going to be so energetic, so happy, and you won't know someone is sick until at later stages. So yeah, those are some of the things HIV causes, I mean, does to these women. Can you hear me?
Yes, I can hear you. I can hear you, Nibol. Continue.
Hello.
You are going to tell us a bit about what the mental effects are on children.
In children, actually, it also causes depression, and then there's that feeling of rejection, and actually one thing that HIV does is that now we're having more households that are being headed by children, because parents are dying, and this is like bringing so much stress on the children. So they begin to feel that they are not doing things normal children are supposed to do. They are faced with having to do what their parents were supposed to do. So this stresses them, and then they have the depression, the anxiety, they feel left out. People look at them as a curse in society. They be like, you killed your parents, you guys are cursed, and such things like that.
Okay. Thank you, Nicole. I think you're breaking up there. If you could just mute yourself. Well, the main thing that you mentioned is depression, and I think you've sort of alluded to the fact that, Yvonne, could you please mute yourself? You alluded to the fact that some of the issues that lead to this depression is basically social isolation, and some of the myths that Dr. Victoria had talked about, the misconceptions about HIV. Dr. Victoria, could you mute yourself?
Pardon?
Dr. Victoria?
Mm-hmm.
Could you mute yourself, please? Nibol? So Nibol has alluded to depression as one of the things that can happen when it comes to mental issues, both in women and children. And the reasons that she has given are basically the effects of the virus itself on the brain, and also the effects of stigma and social isolation. And the fact that even children are exposed to a lot of stigma because of that, because they are told that they are the ones who have killed their parents. And this alludes to what Dr. Victoria was talking about, the myths and the misconceptions around HIV/AIDS. People are thinking that it's witchcraft, or you've been cursed, or because of that curse, then people around you are dying. So if Dr. Victoria, can you unmute yourself? I'd like you to go a little into the stigma index you were talking about. If you can give us a brief overview of what it looked into. Dr. Victoria?
Yes, and actually the stigma index study was conducted by South Sudanese Commission, which is the political wing task for advocacy and lobbying. And it was also with support with the two civil society organization of South Sudan people living with HIV and National Empowerment for Positive Women United. And it came out with, it's actually a stigma and vulnerability study. And it pointed out that self-stigma is very high among people living with HIV. And it's one of the reasons why people don't want to access treatment. In the program, we have people going all the way to Numali to get the drugs because they don't want to be seen at Juba Teaching Hospital. They can go, they move from Qatar to Muniki PACC because they don't want people in the area to know they are positive. So self-stigma is quite high among our populations. Stigma in general is very high. Unfortunately, even health workers have been found to stigmatize clients living with HIV, which is a problem. Neighbors have been stigmatizing clients on living with HIV, including families themselves. Like people living with HIV has been stigmatized with.
Sorry, Dr. Victoria dropped off there. Dr. Melvin, could you unmute yourself? So Dr. Victoria has mentioned a bit about stigma and people not accessing treatment in their areas because they're afraid that their neighbors will see them. Dr. Victoria?
Yeah. Sorry, I cut off again.
Would you like to continue? Would you like to continue?
Yeah. So we've been trying to do a lot of work on stigma, especially with the network of people living with HIV. We've used expert, we call them expert patients, people living with the virus for 30 years, for 40. We have people who have lived with the virus for 30 years and 40 years in Juba. So we use them as expert clients, and we use them in the facilities to help with adherence, because they talk about their experiences, their life experiences. They talk about their experience with the treatment, side effects, and they encourage other people living with HIV to come for treatment. We've been using them as mentor mothers in PMTCT to support pregnant women.
Okay. Sorry about that. I think we'll go back to Dr. Victoria, and she'll tell us a bit more about the expert patients. Dr. Melvin, Dr. Victoria has talked about people avoiding their areas or avoiding certain hospitals where people might know them so that they can access treatment in other places. So could you please tell us about HIV treatment, what it is, how it works, and if possible, then maybe talk about some of the reasons why people do not continue their treatment as they have been advised. Dr. Melvin. Okay. Dr. Victoria, we'll get back to you. Mute yourself for a little while as Dr. Melvin goes into some aspects of treatment.
The treatment we use, it's ART, that is antiretroviral therapy. It's usually taken for life. These people who have the myth of saying when my virus load is low, I won't take the medications, they are all lying. Number two, it's usually done to manage your immune system. It's usually done to boost your immune system because the virus usually suppresses it. You're supposed to take it at a certain time. For example, if you're meant to take it at 7 p.m., take it at 7 p.m. constantly. This is done to maintain the drug at a constant level to make sure that you're keeping the virus at bay. The reasons why some of the patients do not take the drugs, it's due to its side effects. But normally the side effects would vary from 2 weeks to 6 weeks depending on the person. Some of the side effects you might experience is allergic reactions, diarrhea, weight gain, weight loss, nausea, vomiting, fatigue, rash, and it's usually managed. So we usually encourage people, regardless of whether you're experiencing severe side effects or not, please take the medications because after 6 weeks is a little for you to suffer the side effects, and it's also manageable.
Thank you very much for that, Dr. Melvin. If you could just mute yourself. I think we can go back to Nicole. Nicole, can you hear me?
Okay.
So my question for you
Yes,
is,
I can.
Okay. My question for you is when it comes to mental health services for persons living with HIV, what services are available and what strategies are used to help to give support to these HIV infected individuals, and where can they seek help? And also, if you can tell us if you're aware whether these services are available in South Sudan, and maybe we can also ask Dr. Victoria, but for now, Yvonne, how do we support persons living with HIV/AIDS when it comes to mental health?
Okay, thank you so much, Dr. Anne.
I didn't hear the answer. If you don't mind to text me the question. I didn't hear you properly.
Sorry, Dr. Victoria, Yvonne is actually giving her answer on mental health support for HIV-infected persons. Nibol.
Okay. Well, I was saying there's little support for most positions, especially in South Sudan, because now actually most of the patients, people that are suffering from AIDS, either come to Uganda or go to Kenya, or they go up north to like find treatment. So that's what actually people being done in the country system. And for those that are in the country, and like there are those that go to but hospital, for example, and then the majority, so many other people out there that are really not getting the support they need, and I think it's because we haven't created enough awareness. People don't even know where to go. People don't, because obviously of the stigma, they are afraid. They do not have the confidence to walk to any medical facility and say I am HIV positive and need this. So little is being done. Then hello, can you hear me? Hello.
Yes, we can hear you.
Okay, yeah. So that's basically what. And then what
Sorry.
you had said, like what did you ask?
Sorry, Nibol, you're breaking up. I think there's an issue with internet on your side. Can we get back to you? Can we get back to you in a minute? Let's get back to you in a minute.
Yes,
Let me go to Dr. Victoria. Dr. Victoria, sorry. I'll probably throw back Nibol's question to you because you're involved with HIV services in the ministry. is there a strategy for sorting out the mental health issues that are associated with HIV, AIDS, and are there services actually available in South Sudan and support mental health support for HIV infected persons?
Well, the Ministry of Health has a mental health department, and we've been discussing issues of mental health, because even some of the antiretroviral medications cause side effects, and some effects are mental health related. So it is.
Okay, so Dr. Victoria was just letting us know that the ministry has a dedicated mental health department that deals with issues related with mental health across diseases, and HIV
Yes,
is one of the. Yes.
The mental health department at the Ministry of Health and at the Juba Teaching Hospital is yet to be supported, because, as all of you know, until now we still keep mental health patients at the prison, and mental health is still yet to be developed in the country. Although Dr. Atong has done her best, but we have discussed in our TWGs and various interactions that mental health and NCDs need to be streamlined into HIV, because HIV is now becoming, it's not only a disease of its own. We are talking about integration, and the Ministry of Health is keen on implementing integration of HIV in primary health care, integrating HIV into a non-communicable disease, and to be like, to treat HIV not like a standalone thing. So the policy of integration supports mental health and other diseases, because clients living with HIV also suffer from other things. So they should not be treated like, and should be not treated as a solitary kind of thing, but need to be supported in different aspects. And HIV need to be have a multi-sectoral approach and multidisciplinary team involved with the HIV clients. It is something that's been discussed. It's in the pipeline, but at the moment it's only the ART that deals with them, and they get referred to the mental health clinic if there's any issues with mental health.
Thank you for that, Dr. Victoria. I think it's something that's also, if you could mute yourself. Thank you for that explanation. I think it's also something that the audience was interested in knowing about the integration of services, in the sense that what we call missed opportunities are not something that happens regularly. So if the ministry is working towards integrating a multidisciplinary approach to the management of persons living with HIV, because there's so many issues that they face that are not necessarily medical related. They face issues of lack of economic empowerment. They face issues of nutrition. They face issues of mental health, and the ministry working towards a multidisciplinary kind of care is important, and especially setting it up in our institutions so that we don't have missed opportunities, and we're able to look at what a person in an all-round way, so that we're able to take care of all their needs and not necessarily just medication, but also how they fit into their society, how they're integrated, and how they're able to be able to how they are able to avoid being stigmatized, and how the community is able to also help with that. Now, Dr. Melvin, I'll go back to you. If Dr. Victoria can mute herself. Dr. Melvin, unmute yourself. So, Dr. Melvin, I think the most important thing with any illness is that we need to focus on prevention as much as possible, so that we don't get to a point where now we have to deal with the disease and we have to deal with treatment. So could you please give us a brief overview of what some of the preventative strategies for reducing HIV transmission are, and especially in relation to prevention of mother-to-child transmission, because we are all women and we have children, and those who have HIV infection would of course not want to pass it to their children. And we know that most of the cases of HIV infection in children are transmitted from mothers. So what are some of these preventative strategies, and if you could focus a little on mother-to-child transmission and prevention of that.
Okay. One of the strategies is you use a condom every time you have sex. Get tested with your partners. Reduce the number of sexual partners you have. Get treated for STIs, sexually transmitted infections. Then consider PrEP if you're living with a partner who's HIV positive. For prevention of mother-to-child transmission, number one, you should visit ANC. ANC usually cover services like counseling, testing, and linking to a treatment center. And if you're a HIV positive mother, make sure that you've started your ART therapy. It's usually best for your baby and it reduces the chances of your baby getting HIV. If you're a mother who's HIV positive also, make sure you deliver in a facility which is equipped with managing you and your baby, because your baby will be started on ART also. That doesn't mean that your baby is positive. It's just medications given to prevent your baby from getting the virus. And it's usually given for a period of up to 6 weeks. And testing is usually done in intervals. It's done at 6 weeks, done at 6 months, done at 18 months, and usually done at 2 years. So the earlier you start your ANC and your ART therapy, the better chances of your baby not contracting the HIV. Another issue I think people might be asking is about breastfeeding if you're a HIV positive mother, and the chances of you transmitting the virus to the baby. It's usually advantageous to breastfeed the baby regardless of whether you're HIV positive or not, because the baby is already on ART therapy for prevention of the virus.
Thank you so much, Dr. Melvin. I think that is something that most people have a concern about, especially when it comes to mother-to-child transmission. We know that with the introduction of antiretrovirals, we have been able to reduce the transmission of the virus to children by a significant percentage. What they say in the literature is that it has dropped from about 45% at the highest to 5%. And the idea is to prevent transmission when the baby is in the tummy, when the baby is being born, and when the baby has already been born and is breastfeeding. I think the other question I came across was people asking about options when it comes to, if you decide as a mother that you're not going to breastfeed your baby because you're HIV positive, and you need an option, and you come from like you really don't have a lot of money and you want an alternative to breastfeeding or breast milk. Of course, we know that especially in our society and in these low-income societies, what is usually encouraged is that the mother should breastfeed for at least 6 months exclusively, whether they're HIV infected or not. But the idea is to ensure that that mother is on antiretroviral treatment while the breastfeeding is going on, so as to reduce the chances of transmission to the child. But what other alternatives, in case a mother decides not to breastfeed the baby, what other alternatives do they have? Dr. Melvin.
Okay, there's wet nursing. That is when you use your relative who's HIV negative to breastfeed your baby. It was usually done during the olden days, but it's still encouraged. With wet nursing, make sure that you know the status of the person who's going to breastfeed your baby. Number two, people use milk. I think here we usually buy it at 50 shillings. This milk that people usually make tea with. And they usually mix it at a ratio of 1:1. But to make sure when you do that, you don't breastfeed. You don't mix the feeds. That's what I mean. Another option is naan. It's a milk powder sold in a tin can. The disadvantage of it is that it's usually expensive, so not affordable to everyone. So I'd prefer people would prefer to use the milk that is sold in packets instead of the naan. The disadvantages of using the non-breastfeeding method is that, one, you need to be a very clean mother, because if you're not, you're going to expose your baby to certain diseases such as diarrhea and vomiting, and that will lead to malnutrition. So you need to be a very clean mother. Number two, it's usually also associated with failure to grow. So make sure when you're using the non-breastfeeding methods, you feed the baby as regularly as possible. Pediatricians usually recommend up to 8 times in a day. So don't skip the feeds. Make sure you feed the baby as much as often as possible. Thank you.
Thank you so much, Dr. Melvin, for that information. So if you could just mute yourself. Nibal, we get back to you. Unfortunately, your internet has let you down a bit. Okay, I think she's dropped off. So, Dr. Victoria, let's just go back to you. In your experience in South Sudan, what do you think is the effect of our culture, especially in terms of leading to high rates of transmission of HIV/AIDS, especially due to the fact that there's a lot of polygamy that's practiced. There's a lot of issues with open discussions on sexuality. What role has that played in increasing HIV transmission in our country?
I didn't get you quite clearly well, but I think you're talking about reasons for leading to HIV transmission in the country, right? Yeah, mostly the transmission in the country it's mainly from polygamous relationships, and we have done something called mode of transmission studies, and the mode of transmission study have shown that the majority of infections come from female sex workers. These are the key populations, and their clients, and mostly the uniform forces. So uniform forces and female sex workers are the biggest contributors to infections, HIV infection in the country, and mainly polygamous relationships. Unlike other countries which have IV drug users and MSM, men who have sex with men. Here it's mainly heterosexual sex, and mainly female sex workers and uniform forces and truck drivers, border drivers. These are the main drivers of the epidemic in the country.
Thank you, Dr. Victoria. Is there a particular policy in the ministry that targets these specific groups that have been identified as the main drivers of HIV transmission?
Yeah, these are the main drivers of the epidemic in the country, according to the mode of transmission studies. Uniform forces, female sex workers, and truck drivers and border riders.
Dr. Victoria.
Yes, Anne.
Sorry, I think we have lost Dr. Victoria again. So, Nibal, are you available to answer a question? So we're running into a few issues with our internet. Dr. Victoria, can you hear me? Can you hear me, Dr. Victoria?
And I think you're breaking up again, and I can't hear you.
Okay. Okay, fine. So maybe we can go to Dr. Melvin. So just mute yourself, Dr. Victoria. We'll go to Dr. Melvin. So Dr. Melvin, I think we'll have sort of a last question for you. And what do you think are the direct and indirect effects of HIV infection in children, whether they are the ones who are infected or it's their parents who are infected? What are some of those effects on them and their well-being?
Okay, let me start with the direct effects. For the children, mostly it's frequent illnesses. They'll visit the hospital more often than any other person. Failure to thrive. Then because of the frequent illnesses, they'll miss a lot of classes, so the education will be limited to them. There's also stigmatization. For example, the neighbors will be will not allow their children to play with a HIV positive child, and they'll miss out on the experience of being a kid. Children will also experience school dropout because they are not sensitive. Hello? They are not sensitized on how to deal with a HIV child in a class. So they'll tend to drop out of school because of stigmatization. There's also mental illness, like what Rachel was talking about, psychosis and depression. And there's a high tendency of such children to develop drug abuse, such as using alcohol and marijuana to calm themselves down. For the indirect effect, it's because of the parent having the HIV, and we'll talk about maybe a parent loss. Growing up as an orphan will lead to physical, mental, and social issues. Then a parent with HIV might not be strong enough to get a job, so the child might experience poverty and malnutrition. Then due to parent loss, the children might also
I'm
develop
sorry.
behavioral.
I think today we're having quite a number of issues with our network. Dr. Victoria, are you available to comment on the question that I asked? Dr. Victoria?
Anne, are you?
Sorry. Dr. Victoria? Okay. Dr. Melvin, go ahead.
Okay, they might experience behavioral changes due to loss of a parent, such as delinquency. I think she's back. And depression. Then children with HIV parents also suffer from stigmatization and discrimination, and loss of security because of loss of parents.
Okay, thank you, Dr. Melvin. I think that is information that is quite good, and I think you've gone into some of the details in terms of how it affects children. And as you can see, it actually affects children more than adults, because now they have to take care of themselves. They have to take care of their siblings. They can't take themselves to hospital. They can't take themselves to get medication, and therefore, among all the populations, they're actually the most vulnerable. Dr. Victoria. Dr. Victoria? So Dr. Victoria has dropped off. What I was asking her is whether there are specific policies that target some of those groups that have been known to drive the transmission. And I think for our country, as she said, most of HIV transmission happens because of sex workers, because of long distance truck drivers, because of our culture of polygamy. And I think also the culture of not openly discussing sex and sexuality also is a driving force behind transmission of HIV. Dr. Melvin, do you have any concluding remarks, anything that you would like our audience to know specifically about HIV transmission, its prevention, and the need to actually know your status? What are some of your concluding remarks for this discussion?
HIV is not a death sentence. It can be managed, but not treated, but it can be managed. You can live a very long life when you have HIV. It can be prevented by practicing safe sexual practices, using a condom every time you have sex, reducing the number of partners you have, get tested as regularly as possible. For the children, please protect your children from child abusers. Protect your children. If you're a HIV mother, there are drugs which are there to prevent infection to your children. And as a society, for the society as a whole, please don't stigmatize people who are HIV positive. And be free to talk about it. The more you talk about it, the easier it will be for people who are infected with HIV to manage through the through the society as people among you, as your brothers and as your sisters.
Thank you so much, Dr. Melvin, for that summary. Unfortunately, today our panelists have had a few issues with the internet. We've been having this problem with people in Juba, although we really need people in Juba to be part of the panels because we're discussing our country and they are on the ground and they're able to tell us exactly what is going on. I would have wished if Dr. Victoria could just log on again and Nibol to give their concluding statements. But even as they do that, I'd like to thank everyone for attending. Dr. Victoria, thank you for coming back on.
Hello, Anne. Yes, and sorry, I lost the connection again.
Okay.
Yep. Regarding the key populations, female sex
Dr.
workers.
Victoria, if you could give your concluding remarks.
Okay. Okay.
And then probably just tell us a bit about the challenges and how the ministry is trying to mitigate those challenges. Dr. Victoria,
okay. I just basically want to thank you, ladies, for arranging such a platform. Although the internet was really bad and
okay, unfortunately, Dr. Victoria has dropped off again, but I hope she'll be back. And I agree with Dr. Melvin when she says that HIV is like any other chronic illness. And if you take your medication, if you get followed up as indicated and as appropriate, then you're able to live a full and long life. And what is important for us as the community and those who are not infected or affected is to ensure that we do not propagate the stigma against people who are HIV infected. Dr. Victoria, are you able to give us your concluding remarks? I can see you on the screen.
Yes, Anne.
Dr. Victoria, concluding remarks.
Yes, Anne.
Dr. Victoria?
Yes, Anne.
Okay,
yeah.
Dr. Victoria might have dropped off again. So, Nibol, if you could please unmute yourself. I'm sorry you've not been given the opportunity to answer a number of questions because we're having an issue with your internet. Could you unmute yourself and maybe give us concluding remarks? Nibol? Nibol? Yes?
Yes, I just wanted to say
okay, thank you so much
for this opportunity.
I think
I'm really sorry my network was terrible. My network was very bad, but all in all, I just wanted to say that the HIV program through the years, and we've tried our best to scale up HIV services to everybody. We try to adopt a human right-based approach and allow.
Nibol, I think your internet has decided we're not going to hear from you today. So we'll go to Dr. Victoria. Dr. Victoria, concluding remarks. Nibol, you can mute yourself. We can't hear you clearly. So Dr. Victoria will take over and give her concluding remarks. Dr. Victoria? Okay. Unfortunately, we've lost Dr. Victoria again. Well, I think we'll just end this session because we are having quite a number of challenges with the internet. So as I said before, Dr. Melvin is right when she says that HIV is a chronic illness, and if one takes the medication as required, and if one goes for follow-up, then we are able to actually control the infection, and someone does not progress to AIDS, which Dr. Melvin had described and talked about at the beginning. I think some of the things that we have gone through in this discussion, despite the internet challenges, are some of the issues that drive the high rates of infection in our country and among women and children. We have also looked into what are some of the signs and symptoms of whether you have HIV or not, some of the mental and psychological health effects of HIV, and the government policies that have been put in place to ensure decrease in rates of HIV transmission, and to ensure that the people who are HIV positive are taken care of. Now, I think the one thing that has come out from this discussion, as far as I can tell, is that stigma is a driving force against people with HIV infection accessing healthcare, because it leads to discrimination in all aspects of life, whether it's healthcare, even by healthcare workers, at workplaces, in the community, and even at home. And this has led to issues like gender-based violence, sexual violence, and harassment of people who are HIV infected. And I think the solution for stigma remains with us as the community, as the people who live around people who are affected or infected. It is up to us to take it upon ourselves to ensure that stigma is not something that is as prevalent as it is now, and that the myths that people have about HIV infection and its transmission are gotten rid of, because HIV is an infection that can affect anybody. It can affect me, it can affect you, it can affect anyone. It does not choose. And the most important thing is to ensure that you take into account prevention to ensure that you don't get the virus. And for those who have, we should treat them with kindness. We should not stigmatize them, and we should realize that this is a chronic infection that can be managed. So stigma is the one issue that as South Sudan we should deal with. And I think some of our members mentioned about the role of civil society organizations, which I think Dr. Victoria also went a little into, in ensuring that the stigma is reduced, that there is advocacy for HIV prevention and advocacy for reduction of stigma, and that even people in the media, of course, can involve themselves, people in the community can involve themselves, healthcare workers can involve themselves, and even HIV-infected patients, because Dr. Victoria has talked about the expert patients. I want to thank all our participants in the panel today. Despite our challenges, we have tried to answer some of the questions that have come up. I'd like to thank Dr. Melvin and Dr. Victoria in absentia, and Dr. Ayat, who was unfortunately unable to make it, and also Nibol. So thank you very much for joining, and we look forward to seeing you in the next topic. Thank you.